welcome to a spotlight on issues for the League of Women Voters of Vermont. I'm Janet Cramer, a member of the League of Women Voters Member-at-Large unit based in Brattleboro for the whole southeastern section of Vermont. And we're looking today at health care. The League is well known for being nonpartisan while encouraging all citizens to be involved in elections. But we also take time to study issues, take positions on them, and then advocate very strongly for them. My guest today is Peter Albert, Senior Vice President of the Brattleboro Retreat for Governmental Relations, Primary Link, and the new President of Vermont Collaborative Care, a consortium between the Brattleboro Retreat and Blue Cross Blue Shield of Vermont. Welcome, Peter.
Thank you, Janet. It's nice to be here.
I want to review a little bit for the League's position on health care and then look at how that is enhanced and affected by Vermont Collaborative Care. In 1990, the National League of Women Voters, which means leagues throughout the country, began a two-phase study of health care in the United States. We looked at the delivery and the policy around health care in the first 2 years, and in the second 2 years looked at health care financing and administration. One of the main concerns of this study was what it meant to have basic health care. And the study said it is prevention of disease, health education, primary care, including prenatal care and reproductive care, acute care, long-term care, mental health care, and although they felt it was very important to have both dental and vision care, but that study at that time saw that of lower priority. In administration, the consensus on the study showed that we believed a combination of private and public sectors or a combination of federal, state, and local agencies should be used to finance and support the health care. Peter, I was fascinated to begin to learn about the consortium between Blue Cross Blue Shield and Brattleboro Retreat. How did it start and what's happening now?
Well, Janet, again, thank you for letting me be here. And I have to say that there's just a lot of conversation going on about healthcare. And some of it is simple to understand. Most of it is very complex and difficult to understand. It's challenging and it's exciting. And on behalf of the 800 plus people with whom I work at the retreat, I want to say that it's a wonderful opportunity for the retreat to be involved with this. And our ultimate goal is to take all the things that we're learning about healthcare, medical care, mental health care, addiction services, and as we learn, apply those things going forward so that wherever we end up, it's something that's very important for the people that who are our neighbors in Vermont. So we're very excited about this. I would also want to thank Blue Cross Blue Shield. They're the largest health plan in Vermont, and they have clearly put a stake in the ground about how important the concept of integrating mental health and medical services is for overall well-being. There's a phrase that I've borrowed from a number of people, which is, if you're not at the table, you're likely to be on the menu. And for mental health services and addiction services, we've not been at the table for years. And it makes us easy prey for budget cuts and for misunderstanding and for not appreciating the role that mental health services plays in the cost and quality and outcomes of medical care. So Blue Cross Blue Shield of Vermont clearly has stated that mental health and addiction services needs to be at the table, planning and thinking ahead, and we're just very excited about that.
Peter, how will this affect individual, I would call them clients as a clinical social worker, you indeed would call them patients perhaps?
Yeah. Well, I'll give you a little structure of Vermont Collaborative Care and our work with Blue Cross, and then we can move into that. We hired Dr. John Koutros, who's a child and adult board certified psychiatrist from the University of Vermont, and he serves as our medical director. And we've hired licensed mental health clinicians who live and work in the state and registered nurses who have mental health background to join our team. And we have them sitting side by side with the current medical staff at Blue Cross in their offices in Berlin, Vermont. And just sitting side by side doesn't equal integration. So we have intentionally looked at how we train people and how we supervise people and how we think about care, how we've integrated the IT system and our budgets so that the impact for individual clients, as you've mentioned, should be absolutely seamless. The advantage of this is in the past, when people had a Blue Cross Blue Shield card, there would be one phone number on the back to call for medical services and a second phone number to call for mental health services. And one of the first things we did to really identify what we wanted to do was we created one number. Mm-hmm. So someone calling in gets the same customer service, the same intake, and the same clinical services as anybody else would. And then from there, it's a process of engaging people and working with them to determine what makes the most sense in terms of care for them. The other big part of this, to step back a little bit, is that this means that we start thinking about healthcare very differently. We have to create a model that really challenges some of the existing norms. In the past, health insurance was something where people, it was transactional. You filed a bill, you got paid. You submitted a claim, you got paid. You were looking for services and you went to see somebody and you submitted a bill. In more recent times, it became a little more sophisticated in terms of identifying case management services and thinking about connecting people. And that's okay as well, but we're now talking about really shifting the paradigm and talking about wellness and talking about how can a health plan, or in this instance, Vermont Collaborative Care, get out of the way of the most important relationship, which is the provider and the client, the clinician and the patient. And how do we redefine what the role of a health plan is? How do we support the work that's being done? How do we think about the structure of it? How do we think about paying for outcomes and value? How do we create a shared vision with clinicians and members and health plans and the community at large? It's a much more exciting and interactive process that research tells us is successful. The World Health Organization, Robert Wood Johnson, there are a number of research articles now that make it pretty undeniable that mental health and medical care have a definite impact on each other. And if you have one condition and you don't pay attention to the other, the cost goes up significantly, almost twice as much. Your quality of life is diminished. So we need to pay attention to the whole person. And at its heart, that's what Vermont Collaborative Care is about.
Knowing our concern about how the government fits into this, how do you see Vermont Collaborative Care interacting with Vermont's Act 48, which is the single-payer health care, and then I think you reminded me of Act 79, which has to do with mental health.
Right, right. Well, my excuse on not understanding the finances all the time is that I'm a clinician. And I must say that I am less concerned about the functionality of paying for, because I think unless we change the delivery model and system, unless we change how providers and members interact with each other, we could just be paying the same amount of money for a different system. So I think that's a part of it, but my responsibility and what I look at is I recognize that people's wellness is based more on behaviors and genetic makeup, environmental, social interactions that people have, than in how it's paid for. But if you take the social and cultural aspects of care and you match it up with allowing a provider and a member to do the work they need, and then the health plan, whatever it's single payer or multi-payer, comes up with a very streamlined and simplified process for paying for it that includes paying for outcomes and value, not just fee for service where you're on an assembly line. And if everybody accepts and believes in that concept, then payment moves forward with the overall model.
In your studies, as you say, you have a lot of work to do. The definition of outcomes would seem to me very important.
Yeah, the outcomes are very important, and it's one of those words that you can beat people over the head with, and you can hold them responsible for something, but you're never quite sure what they are. And I think part of that is that historically, health plans, managed care companies, government, they were the ones that defined what outcome they were looking for. And I think what we're talking about and what we've started to do is sit down with clinicians and the people who actually receive the care together and say, what is it when we define outcomes, what is it that we're looking at? There are a lot of tools out there that you can use that might be good grounding. But what is it that we value in healthcare? What is it that we know that enhances our lives and improves our level of functioning? So it would be a really big mistake for us to start with this by defining for others what the outcomes are. Part of our role is to sit and facilitate the conversations. And then once we come to agreement and we have a shared vision, then we talk about how do we support that moving forward, and then how are we all held accountable for reaching those goals.
Certainly there has been, as I'm looking at the standards for equitable financing of Green Mountain Care, so far there has not been a defined list of benefits. You've got to have this, but there is real concern that all of the medically necessary care be financed and provided. And when you and I talked about this earlier, we talked about how important it was to change the stigma of mental health care in conjunction with physical health care.
Yeah, I thank you for bringing that up. I think the most insidious and powerful deterrent for people looking for care is the whole issue of stigma. And I think I would look at people and ask people, in your families, in your neighborhood, in your friends, in your own life, who's not been touched by someone with a concern for mental illness or addiction? Who's not seen it untreated damage the lives of many people? And we need to address that, and we need to be able to talk about mental health care and addiction care in the same vein we talk about diabetes, asthma, and heart conditions. And to that, one of the things that you do, you then have to reach out to the larger community. And for an example, primary care physicians, they are the largest providers of mental health care, bar none.
And probably the largest prescribers.
Well, you just took my line. And they are the largest prescribers of medications. And 25% of the people who go in to see their primary care physician have some form of a mental health issue to deal with. And this is on a spectrum of something small to something large. And primary care physicians have so much work to do in a very short time. And they're not necessarily trained. And when you talk to them about doing screenings and triaging, they're very interested in doing it. But the question that they worry about when you sit and you talk with them, which I've done a lot of, is what if I find somebody? What is my responsibility? Who do I refer to? Can you make it easier for me to find somebody in the community that I can just refer somebody to and make it very simple to do? And I think that's our obligation. And part of what Vermont Collaborative Care and Blue Cross is going to do is build more alliances across the continuum of services and bring people together to talk locally about who are the people who will guarantee access. How do you communicate back and forth? Because it's also it's a very subtle issue in terms of people's privacy. We all have different relationships with our primary care physicians. Some of our primary care physicians know us quite well, and sometimes you don't see them except for the annual physical. So you want to be careful about sharing and what you share. So the concept of integration is a layered one, and you need to take the time to talk to people about how do we address this, respect people's privacy, but really work together. I'll give you something else in terms of numbers and why this is important. If you look at a continuum of care, by and large, the numbers may vary, but basically anywhere from 2 to 5% of people will consume up to 50% of healthcare dollars. And these are the people who have significant chronic illnesses that you're helping to manage over the long term and enhance their quality of life as best as possible. On the other end, there may be close to 50% of people who are basically healthy and absorb very little of the resources. What we're trying to do at Vermont Collaborative Care and Blue Cross is to look at that chunk in the middle that on a continuum may have one chronic condition, and by that I mean somebody with high blood pressure or high cholesterol, all the way up to people who may have 2 or 3 chronic conditions that may be significant. And the goal there is to figure out what assistance, if any, do the people sitting in that bucket need to manage those issues so that they don't move over into that high end, and so that their quality of life can be improved. And that requires, as I said, a lot of conversation, a lot of looking at data and analyzing, always with an eye towards people's privacy, including them in the process, identifying values and outcomes, and then closing the loop. Okay, we've done this, we've tried this, is it helping, is it not helping, what do we do to change? And if we find something that works, then spread it around to see if it works more in other places.
Okay. Well, Peter, you led me to where I also need to go, which is the looking at the people at the serious end of mental health issues and what the retreat has stepped up to do for the state of Vermont after Hurricane Irene.
Yeah.
Indeed, there has been a private-public collaboration, which I gather from articles both at the Commons and the Reformer, has not always been easy. So I'd like to take this opportunity to, how is it working and what needs to, both what needs to change, but what's going on?
Yeah. No, you know, being part of the community, I think it's important that people understand what's going on, so thank you. Just to step back and put this in context as well, we're coming up on the 2-year anniversary of Tropical Storm Irene. And when that hit in August, it managed to resolve the argument that people in Vermont had been arguing about for 10 years about what to do with the state hospital. So Irene hits, and in the morning we get a call saying, "Can you help?" And by that evening, there are 16 individuals who arrived by bus who have been at the Vermont State Hospital for a number of years. They have a sense of where they're going, but their whole lives have been tossed up in the air. During the course of that day, we made a very quick decision. We checked with our board of directors, we looked around at our campus, we looked at our staffing, and we basically said, we're a part of this community. There's help to be provided. We need to be a part of the solution. So we put plans on hold that we had to open up a new unit, and we looked at our staffing and moved people around, and we said yes, we would take people, and we thought we were doing it on a temporary basis while final plans could be implemented. And we said that we thought that we could do a small unit of 14 people. So that's where we started. And when I referenced early on challenges and excitement and you know, fixing the bike as you're riding it, this is one of those examples of you step up to do what you know is right, and you work as fast as you can to educate and train yourself, and you never walk away from conversations or a chance to learn and improve. And that's what we've been engaged with. And sometimes we've been very successful with CMS reviews.
CMS needs translation.
Oh, CMS, Centers for Medicare, Medicaid, the federal government that provides regulation over hospitals. And we've been very successful with the Joint Commission, which is a second national organization that oversees hospitals. They actually, when they reviewed us last fall, took a number of our processes and identified them as best practices. But you know, as anybody who's read the paper, listened to the radio, watched the TV, we've clearly had instances where we have room to grow, excuse me, and things that we need to learn, that we're not walking away from and that we will learn. We did this last year when CMS came and found us lacking in certain areas, and we put together a quality improvement team, submitted a plan of correction. They came back last summer and said, you're doing absolutely fine. Keep doing what you're doing. Now, that's not to say that the road is smooth, because it's not. And we're again in the process of having submitted a plan of correction to identify things that we need to do to enhance our planning and training. And we fully expect that we will again do that. But we're not doing this alone. We had agreed to take 14 people. We have, over the last 2 years, been averaging as many as 25 people and as high as 28 people, so that they're not just on one unit where you can focus on very specific treatment, but they've moved into several other units. And the demand is out there. Emergency rooms still have people who sit for hours on end waiting for a hospital bed. When the state talks about having a mental health crisis, we are still in crisis mode. We should not pretend that we're not. There are not enough resources in place. There are not enough inpatient beds in place. The community resources are stretched thin. The mental health centers are doing a phenomenal job, but they don't have as many resources as they need to have, and they're building towards that. We don't have enough step-down beds where people, when they're ready to leave the hospital, can move to. All of that adds to the frustration. It adds to the length of stay that people are in hospitals. It adds to people not getting into services as quickly as they need to. So that's the strain that the entire state is under. To the state's credit, though, and when I mentioned Act 79, the people in this state, from the governor to the commissioner of mental health to legislators, we have a phenomenal group of local legislators who are incredibly invested in looking at this process and making it better. There's a commitment being made through Act 79 to say, no longer will we have one central state hospital where people go and are forgotten about. We're going to decentralize the system. We're going to involve more hospitals, more community services. We're going to require that people have more conversation. And the really additional exciting part of this is we're going to include peers and patients in the process. This is your treatment. What do you think about it? So we have a peer recovery advisory group at the retreat. They actually assist in orientation of new staff. They run wellness recovery action program groups, which is Mary Ellen Copeland's RAP programs on our units.
I'm familiar from one of the members there.
All right.
I'm delighted.
Yep. They do a phenomenal job. We have representatives from DRVT, which is Disability Rights Vermont, there. We talk, and we don't always agree, but we are hopefully creating an environment where people can say what they need to say and together resolve things going forward. So it is incredibly challenging. And it would be totally inappropriate for me to say we know everything that we're doing. There are things that we're continually learning, but in the process we're also providing what I think is exceptionally good care. The staff there are totally committed to patient care and people, and work very hard and are very focused on what they need to do, and are as involved from the top level on down in working together.
Has taking the state-mandated patients, because I'm assuming that otherwise people could choose to come to the retreat, so that the state-mandated patients, do they present a different challenge to the retreat?
I think they present a different challenge to the entire mental health system. Rutland Regional Hospital is accepting some of these patients, Fletcher Allen is, and when we talk together, we talk about the challenges that it creates. Because these are people who are in the care and custody of the Commissioner of Mental Health, which means that they don't want to be in the hospital. Someone has deemed them to be at imminent harm to themselves or someone else. So they're not voluntary. So it does add a layer of complexity in terms of engagement. and in appreciating the power sometimes that mental illness has over people. So it has created an extra acknowledgement of what is the extra training and expertise and staffing formulations and programming and actually the milieu itself, how should that be constructed? As some people may know, we've received money from the state, and several months ago in April opened up one of our units specifically designed to treat this high acute level population. And we had an architect who worked specifically in creating these types of environments with us. We had our peer advisory group working with us. We had people from the state looking at plans. So you look at the environment of care, you look at the staffing and the training that's required, you look at what do you do in terms of a quality improvement process to always look at what you're doing. Because as you've noted and I've agreed, people coming in who are in the care of the state add an extra level of challenge. And I would say the other part of this that people should know is, as we've been doing this, and it's not just us but other hospitals, people who are voluntary who want to come in, we've had to say no to because the bed capacity isn't there. So every week we're having to turn people away. And the worry is, well, where do they go? You know, when they leave the emergency room, where do they go? People have said to us, well, did you take too many state hospital patients? And I think that's a fair question. The answer is not easy, because where would they be? They'd be in emergency rooms, they'd be homeless, they'd be living on the streets. They are people who are in need, and we as a system have to figure out how to meet that need.
Peter, I want to thank you for a very informative discussion, a challenge to all of us to become more aware of what's going on in mental health, and indeed what's going on in our governmental system, where we take responsibility for people of wide variety of needs. I would encourage any viewers of this program to contact the League of Women Voters of Vermont, LWVOFVT.org, to learn more about the League's position on healthcare, and indeed to learn more about how they, as citizens, can be involved in moving these things that we know are so important into the governmental realm, and where they can be participants in it.
Yeah, and Janet, before we close, I just want to say thank you for inviting me to the table. And you as a social worker and I as a social worker, I think our training allows us to see the big picture, and I'm very appreciative of your understanding and the opportunity to talk about this, because it's the only way we're going to make things better. So thank you very much.
You're welcome indeed. And indeed, again, the League of Women Voters welcomes all interested citizens, both male and female, although we may be called the League of Women Voters. Indeed, since 1972, we have welcomed both men and women, and look forward to active participation in government, both at elections, but after election in the activities of your government. Thank you very much.